If they have, again, sort of arbitrary time limits on I support VBAC if it doesn't take longer than 12 hours or 24 hours, that's not a supportive care provider. You want somebody who's open to understanding that labor is not a linear process and no two labors are going to be the same and no two VBACs are going to take the same amount of time. And looking at you as it goes back to as an individual and a person more than just a patient, and knowing that you're not going to fit in a box to have your VBAC.
Welcome to the Birth Education Center podcast, hosted by myself, Care Messer, an entrepreneur, birth educator, and doula. My team and I want to help you discover your options in birth and postpartum, how to find your voice, and how to use that voice to navigate our maternal healthcare system. You and your baby are not just a number. This information includes doulas too. Now let's get started. So we're back today, Ashley and I, talking about VBAC in our little VBAC series. And today's topic is going to be about providers. And top of my head, though, I want to say right from the beginning, if you're in an area of the country where your hospital does not offer 24/7 anesthesiologists at your hospital, they will not do VBACs at that hospital. Because if you needed an emergency and they don't have anybody who can put you under quickly, etc., it's not safe for them to do it. And I know people don't want to hear that, but as we're getting more and more maternity care deserts in this country, you may need to relocate yourself for that last part of your pregnancy so that you can have the option of a VBAC. And I don't want us to set you up for, yes, I can do this. And then you find that that's what's happening in your area. So cost prohibitive, maybe even to travel outside of the area or even take other kids to go outside of the area might be impossible. But I wanted to mention that right at the front of our episode on providers, because finding the right supportive provider instead of a provider that's tolerant can make a huge difference in how you are treated with respect, dignity, and understanding while you're doing this VBAC situation.
Well, exactly. And it can be really hard when you feel like everything in your area is not set up for you to pursue your VBAC. Like you can feel like the only one in a 100-mile radius who actually doesn't want to have a repeat C-section. And it can feel really isolated and alone. But we have seen people go to great lengths to achieve their VBACs, come to the US from other countries, move from other parts of California. Even in California, from county to county, we know that there are some counties that are very VBAC supportive and some that are very VBAC intolerant or unsupportive. And so people even move around California looking for VBAC support. And um, we know how hard it can be. So when we're talking about providers, obviously we will always encourage you to go to the furthest lengths that you can to achieve what you want to achieve for your birth, to have your VBAC. But just know that if it's difficult for you, you're not alone. There are a lot of people struggling to find the right care provider for their VBAC.
And sometimes finding the right care provider is leaving the hospital. And sometimes that's out of your comfort zone. Totally get it. But there are midwives and birth centers that support VBAC in a very friendly way. And they want to keep you safe and want to make sure you're in those bounds of low risk so that they can support you out of hospital. And I know that's out of your comfort zone. So that's something that you'll have to research. But especially in North America, we do have a lot of VBAC friendly providers that are out of hospital.
Yeah, and when you're looking for a provider, whether it's in the hospital system or a home birth midwife or a birth center, you want to be really assessing how supportive they are of VBAC, right? So in the birth community, we use a metric where you'll hear people talk about if they're VBAC supportive or they're VBAC tolerant, or they absolutely straight up tell you they do not support VBAC. It's a spectrum.
And I would rather
And
them say, absolutely, I do not support VBAC, and until they drag you all the way through your care and then go, yeah, I just don't feel comfortable with it at the very end after they've led you through that. That's not okay.
oftentimes you'll hear people say like, "Oh, this doctor is VBAC supportive. This doctor is VBAC tolerant." And rarely do we talk about the fact that, home birth midwives are also allowed to be selective about the care that they provide. And not all home birth midwives are comfortable supporting VBAC. So when you're looking for a provider, we can't just assume because they work at X hospital, they're not VBAC supportive, or because they do home birth, they are VBAC supportive. It's really going to take you spending time doing research online, talking to people around you who have pursued a VBAC, doing your research, and we'll kind of talk about different areas of support that you can get as you're preparing for your VBAC. But research is a huge part of it to set yourself up for success, to know who am I talking to about this, who could potentially provide my care, and what questions am I asking them? And that's really what we're here to talk about today, is how do I find someone who is truly VBAC supportive or as close to VBAC supportive as I can find in my area? And how do I decide if their care is right
Well,
for
and that
me?
brings us back to ICANN, right? Finding your local chapter of ICANN. Who's done this before so that you're not reinventing the wheel and starting from scratch, because the women in your area are going to be, they'll be honest. That peer support, number one.
Yeah, you'll hear us talk about ICANN in every episode that we do about VBACs, about cesareans, because there really is no other organization in the world who has made it their number one pursuit to reduce the number of unnecessary cesareans that are done, not just in America, but worldwide, and to increase support for VBAC across the world. And so that's a name that you're going to hear come up again and again and again, and whenever we're talking about these topics, because they really are trying to cultivate a community that helps people reduce their risk of unnecessary surgery and heal from their surgeries and potentially have their VBAC
And I
births.
just a side
So,
note, I had a mom this week that said, if it gets too tough, I just want a cesarean. And I said, what does that mean to you? And she said, they just take the baby out. She hadn't, there was no understanding that actually it is major surgery and there are complications to it. You want 3 or 4 kids. That trajectory can change things for you. And we had a big discussion about it. And what she said was, it's so common and it's so talked about like it's no big deal. And even her OB had said, I had 2 babies by cesarean. It's totally fine. You recover quickly. I got right back to work. And so the minimalization of it just made her think it was no big deal. And sometimes it's not. But in most cases, it is a big deal.
I mean, I think we need to start being realistic about whether the cesarean is wanted or not wanted, whether it was necessary or unnecessary, that we are taking somebody who usually is very healthy and doing major surgery on them, and they have to recover from that and live with the effects of that for the rest of their lives. And that when we talk about VBAC, there's sort of this underlying connotation with the term VBAC that people think it's inherently dangerous, or like it's the inherently more dangerous choice. But that's actually not true according to the data. In fact, a VBAC is considered safe not just by birth workers and doulas, but by ACOG, the American College of Obstetrics and Gynecology, who is sort of the overseeing body for all OB doctors in the United States. That a VBAC should be the top recommendation to someone who's had a cesarean. Why? Because not only are cesareans dangerous, they get more dangerous as you have them. And so there are many OBs in this country who will stop at a certain number of cesareans, whether it's 2 or 3 or 4, because they know that cesareans, because they are surgery, get inherently more dangerous as you perform them on somebody. And VBACs actually get less dangerous with each one that you have. So when we talk about a VBAC and the risk, the big thing you'll hear people talk about is, oh, uterine rupture, which is a very small risk, especially relative to all the other risks inherent in pregnancy and in cesarean deliveries. There's about 1% chance of that occurring. That 1% cuts in half each VBAC that you have. And so if we can set the standard of providing VBAC care and encouraging providers and finding providers and midwives who can step in and step up and provide that VBAC care, we're going to reduce not only the number of cesareans that happen, but the number of complications from cesareans and the number of reducing overall the maternal mortality numbers and injury numbers and all of that goes along with having excessive cesareans. And so when we're talking about this, we're talking about something that even ACOG says should be the standard of care if somebody is healthy and has a healthy pregnancy.
I think that's the trick, right? The governing body is like, yeah, up to 80%, you have a good chance of having a VBAC. We should provide that. That should be the first line of care offered to you. However, we have a lot of OBs that have seen worst case scenario. And we're playing now into their trauma and their risk and their liability, their family's liability for getting sued. Totally understand that, which makes it much more important to find the doctor that you're not triggering all of their trauma and their fear, right? Because the words that are going to come out of their mouth are not going to be supportive. They're going to hint to it's not happening. And that's not going to be who you want supporting your birth. So those filters for you have to be on, understanding their side of it as well. I have compassion for that because they do see worst case scenario. They do see best case scenario, but not very often, right? With the bells and whistles and fairies and dust and unicorns or whatever that shows up. And they think those are like, that was rarity because the kind of care they're providing over and over is just a repeat cesarean and everything's fine and it's done. Instead of, wow, she really accomplished that. And I could really be supportive in that, which is why when we have a supportive provider in town that we know is going to be that cheerleader and really keep it cohesive for our family, that's obviously who we're going to kind of drive them to if possible, because we see the difference. And whether you have an OB or a midwife, you're going to have tolerant providers and ones that really believe you can do it. And when you come up against, yeah, we'll support a VBAC as long as you go into labor before 39 weeks. Why? Do we say that to parents that are just starting out and saying, well, you have to go into labor by 39 weeks or else? Yeah, maybe some of them do, but it shouldn't be, right? Because that's pretty early to go into labor when average is 41 and 3, okay? And then, well, but we don't do any induction methods. Nope, you just have to do it all on your own. And we'll do that, but we're going to place an epidural just in case. You have to be okay with labor, doing your whole labor at the hospital and having an epidural right off the bat. Because just in case we need to get you back there fast, you're already ready to go. Wow. Does that sound like, yes, we want you to have the best supportive, or does it sound like there's so many stipulations? Are you sure you really want to do this? That's what's actually being said. And when we know that a good labor is supported by being upright and mobile and feeling what your body is feeling and going for those comfort measures and working through it until you need an epidural, if you need an epidural at all, that's what's going to help support that labor if that's the vaginal birth that you really want to drive. So, what is that saying when you're hearing all of those things right off the bat? Probably not the VBAC supportive provider, but definitely a tolerant provider.
Exactly. And it's something that we talk about so much about. VBACs happen with rough providers, right? People achieve their VBACs with less than supportive providers, but really getting that VBAC supportive gung ho cheerleader in your corner, willing to go the lengths with you to help make sure you achieve your VBAC and reduce your risk of cesarean. If you can find that, that's what you want. You don't want to have your VBAC in spite of your care
Oh,
provider.
so in
You
spite of it.
want to
Yep.
have, yeah, you want to have your VBAC with your care provider, connected with your care provider because of your care provider, not in spite of the care that you received. And we see so many people, not just in VBAC, achieve incredible births in spite of the care that they receive with, providers being negative the entire time, or, huge groups where it's definitely not their provider showing up for them, it's some stranger. And that can happen. And I tell people this all the time. With your first birth, you can take no classes and not get a doula and show up at the hospital. And, one small percentage of people can do that and accidentally have a good birth experience. You can accidentally have a VBAC without pursuing supportive care or getting people in your corner, without getting educated, without the support. You could
Oh, it's so
possibly,
rare
but
though.
it's even lower than that 1% of 1% of people with their first baby showing up and accidentally having a good birth. We want to do everything in our power to reduce the risk of not only having another cesarean if you don't want one, but having a traumatic birth, right? Having a traumatic experience where you're potentially mistreated or not heard or not listened to and not supported, that leaves you with not just physical things to recover from, but mental and emotional as well, right? That's what we want to help you avoid. And so, again, going back to looking for that kind of care, that this person is here to walk alongside me and keep me safe and empower me to achieve the birth that I want to
Another thing too is,
in spite of
yeah,
them.
you want them to be answering your questions in a non-fear-based mode, right? You're already kind of nervous about it. You definitely don't want to ask a question and then have this fear blurred out answer. Yes, you can tell me the risks and the benefits, but there are ways to approach that are non-fear based that help encourage me to go for what I want. And, there's just so many reasons to have the right care provider.
Exactly. And VBAC supportive means that they are following the medical evidence. It doesn't mean you're never going to have a cesarean with them. It doesn't mean that everybody is going to achieve their VBAC, right? We're looking for somebody who is realistic about the amount of VBACs that they have done, the percentage of their parents that achieve their VBAC, the ones who can recognize what makes somebody a good candidate for a VBAC. And it's like Kara said, when you're upfront about your no's, a provider that's upfront about they're absolutely not. You also don't want a provider who's like, yes, of course, everybody can have a VBAC and it's going to be perfect and all of this. And then it ends up being kind of a bait and switch at the end. You want somebody who's very realistic about the kind of care that they provide, that they're honest with you about their percentages and what they do to help you achieve VBAC support. And you want somebody who follows evidence, who sees the ACOG guidelines and recommendations and says, yes, I'm going to do my best to stay up to date on those to provide evidence-based care. And then ultimately somebody who allows you to be autonomous, which again, another word that you're going to hear from us in every episode probably is autonomy, that allows you to be autonomous and guide your own care and guide the decision making unless intervention is absolutely necessary. And when you're choosing a provider, you want to make sure you are asking questions about what their care is going to look like and what kind of support they're actually providing you to make sure that they are an evidence-based care provider.
Can you go over the questions that we need to be asking our providers so that we have kind of an outline? And I would say even before you are getting pregnant with this VBAC, you should already have your provider before you're even pregnant, because, obviously we want you to wait as long as possible to get pregnant, at least 18 months, so that we've got that scar really healed and we've done the mental work ahead of time. And you're finding your provider during that time, working through any other issues you had from your last birth. But what questions should they be asking their provider as they're interviewing? Because definitely they need to be interviewing.
And I just want to talk on that point really quick before I get into the list of questions. That's such a good point that you make, because I know I can specifically think of a provider in San Diego who is full. He's full all the time. And the only people who can get in with him for VBAC care are people who are already established as his patient before they even get pregnant. And so we'll have people kind of go to him hoping to get a VBAC sort of last minute switching. And he'll be like, literally the only thing I could fit on my schedule would be a scheduled cesarean if you want me as your doctor, because I have so many patients. So if you were unhappy with your cesarean and you are thinking about a change of venue, a change of provider for the next birth, do it before you get pregnant with the next
Definitely go get
baby.
your well
Get
woman
in
care.
care.
Yes, before.
Establish care with the person that you are hoping to support your VBAC well before you get pregnant. And also, you can even shop around when you're in that in between time where you're not pregnant yet and you're establishing care. That's the time to go with these interview questions and talk to doctors and decide, make your changes to your insurance and stuff like that when open enrollment comes around. Whatever you need to do it before. That's one thing that we see, unfortunately, a lot is people who either didn't realize VBAC was an option because they weren't listening to podcasts about it, or people who maybe thought they were just going to schedule cesarean and then something changed and they realized maybe I am too scared, maybe I don't want another cesarean, but they're so far into their pregnancy that it's really hard to find a provider who can kind of take them at the last
And you
minute.
also have to
So
validate, it's really hard to shop around when now you have a toddler. And especially if you're in the early days of healing, first month or two, it's impossible at that point. But you can start getting on the ICANN support groups. You can start asking while you're feeding your baby, what is out there, what's available in my area. But it is tricky when you've got a toddler that you're managing to just show up at appointments and interview people.
if you can, whatever you can do, remember, like when you have your baby, that's a life-changing event. That's the time to make changes to your insurance, or the next time open enrollment comes around after you have your baby before you get pregnant with your next one. Look at who the providers are in your area that are going to provide the type of care that you want. And obviously this goes for everyone, not just for pursuing VBAC, but if you're unhappy, if you had a traumatic birth, if you felt unsupported, grab those opportunities to make those changes when you can, to make sure that the next time you have a better experience, because you deserve it. And when it comes to interviewing providers, obviously the list goes on and on in general. But when it comes to VBAC, there are some important things, and Kara's actually alluded to a few while we've been chatting already. So, a big one is limitations on when you can go into labor. This is something we see with OBs, not just for VBAC, but a lot of providers will sort of have these deadlines. And what happens with VBAC for tolerant providers or unsupportive VBAC providers is they move those goalposts back even further, where maybe they say, hey, 40 weeks for somebody who's not pursuing a VBAC, or 41 weeks for somebody who's not pursuing a VBAC. They will say 38, 39 weeks for a
Ugh,
VBAC
it makes
candidate.
me so mad when they come and tell me that.
It's infuriating. There is zero evidence to support that. That is not by any means an ACOG recommendation. There is no evidence that they need to go into labor before their due date in order to achieve a successful VBAC. In fact, the number one thing that is most likely to make a VBAC successful from a physiological standpoint is spontaneous labor and allowing labor to happen on its own. So, when we're talking about a provider who's kind of making up these limits that they have decided arbitrarily are what they're going to provide, that's not VBAC supportive. That's not even VBAC tolerant. That's just their way of avoiding actually supporting a VBAC, is by automatically taking these babies via cesarean before their parent would have naturally gone into labor, which is so infuriating. So that's a huge one. That's a huge, huge red flag if they say, yep, you can have a VBAC as long as you go into labor by 38 or
Well,
39
and
weeks.
I
Like,
had one
absolutely
mom
not.
who argued that back with a provider, and he goes, "Oh, so you want to go to 42 weeks?" And she said, "Yeah, I want to go to 42 weeks." And he goes, "Do you know how huge your baby's going to be by 42 weeks? And then I'm going to have to get them out of that little hole if we do a cesarean?" And it freaked her out. And I said, "What if you were at 42 weeks the first time and your baby would still have come out the same hole?" That was another way of fear mongering you into complying to the 39-week rule. Your baby was 41 weeks last time. So what's an extra half a pound like coming out of that
Exactly.
hole?
Yeah. And I think people think that there's this dramatic size difference between a 40-week baby and a 42-week baby. And a big baby is going to be a big baby no matter when they come out. And a little baby is going to be a little baby no matter when they come out. And you're not going to have a 7-pounder at 39 weeks and then they're a 10-pounder at 42 weeks. That's not how babies grow. So it's more about control than anything else. And I think for some providers, and this is going to be my, really nihilistic perspective, I think some providers like the idea of advertising that they support VBAC to bring clients in. And then when they put these rules and limitations on their patients that make it so they never actually have to provide that VBAC support, it's a win-win for them because they got clients, they're getting the business, but they don't actually ever have to do anything outside of their comfort zone or provide any type of care other than what is their standard. And so,
Unfortunately, we see that a lot. And I just wish we didn't, but we do see it a lot.
yeah. So another big one that Care kind of mentioned is, do you support an induction if I need one as a VBAC? And guess what? We don't love induction. You know this about us. You hear us say it till we're blue in the face that, hey, please don't have an induction if you don't need one. But guess what? Some people need them. Some people need to be induced. Some babies need to come sooner because our bodies do wonky things, or our health is in danger, or whatever the reasons are why somebody would need or choose an induction. And an induction is absolutely supported with special guidelines for VBACs. There is no evidence that says that you cannot have a VBAC if you're induced, or that you cannot induce somebody pursuing a VBAC. There are certain medications they recommend you don't use. There are certain approaches that they don't recommend that you take if you are a VBAC, but it's absolutely supported by medical evidence that you are entitled to an induction, even if you're pursuing a VBAC. So if they say, nope, no inductions for VBACs, I don't do it at all,
There's your answer.
that's not a supportive provider. Yeah. And it's not evidence based whatsoever. So keep that in mind. One that is sort of a gray area, but it really depends on the type of VBAC you are pursuing, is whether or not they provide intermittent monitoring for a VBAC. So this one is more of a knowing what is acceptable or provided at your place where you're birthing, less about saying this provider's a no-go, because the standard is continuous monitoring for a VBAC. And even the providers that we know and love and work very closely with in San Diego, most of them recommend
And
continuously monitoring a
explain why,
VBAC,
Ashley.
because the best indication that something is going wrong in a VBAC situation is baby's heart rate, is paying attention to what baby is doing, especially when we're having surges or contractions. And so their instinct is to continuously listen to that baby the entire time that somebody is in labor, or as often as for as much of the labor as possible, to make sure that that baby's communicating to us that they're okay. Because the big risk, as you've heard us say, with a VBAC that people talk about is rupture, uterine rupture, and the baby's heart rate is typically the first piece of communication that tells us that that may be happening. So they want to listen to baby continuously the whole time. Now, that is kind of the standard. The evidence is out as far as whether or not that actually reduces the risk of very serious outcomes, if the risks outweigh the benefits when it comes to taking breaks and doing intermittent monitoring with VBAC. The benefits, obviously, of not being on the monitors the whole time is that freedom of movement, that it is less stressful to not constantly be monitored, the ability to get in the water if there's water available in the shower or the bath at your hospital, and just that ability to move your body that is so crucial, especially if you're attempting an unmedicated birth. That we also know that continuous monitoring can provide false indications that something is going wrong, because babies' heart rates do change throughout the labor process, and they respond to different parts of labor differently depending on what's going on or where they're positioned or as they move down in the pelvis. And so there might be some false indications that something's going wrong, and then we do a cesarean and actually there was nothing going wrong. And so there is that slightly increased risk of an unnecessary intervention because we're listening to baby the entire time that we're in labor. When best evidence for monitoring is checking in, once an hour or 5 minutes before, during, and after a contraction for people who have not had a
Well,
VBAC
and
or
Ashley, have
who,
you ever had, because I don't remember if I have or not, had anybody on the wireless monitors with a VBAC? Oh, you
yes,
have. Okay.
yes. Yeah. And so that's a really good option too, is when you're talking to your hospital or provider about, if, hey, I love supporting VBAC, but I really need you to be on the monitor the entire time. Okay, what kind of wireless monitoring options can you provide for me? And I know for a fact in San Diego that every hospital now, nearly every hospital, has a wireless monitoring option that's perfect for not only VBAC, but for inductions as well, or people who are having some kind of medication during their labor that might make them a higher risk. That those wireless monitors are chef's kiss, because they allow the provider to feel comfortable that we are keeping a very close eye on this baby while allowing the parent to move freely during their labor. Um, and I love especially the sticker ones that they just kind of set it and forget it. That's what I usually tell parents about it. I've had people put the sticker wireless monitor on and they don't touch it for 12 hours and they just straight up listen to that baby the whole
They're
time. And
phenomenal.
we're not adjusting bands and moving monitors, and it can get wet, and it's amazing. So talking to your provider about what type of monitoring they prefer for VBAC, why, allow them to share their why with you, and then what are your options. And then if I say to my provider, can we come up with some type of intermittent option, a lot of times they're very open to that. It may not be the standard of 5 minutes every hour, but maybe it's 30 minutes on, 30 minutes off, or something like that, where both of you kind of get the best of both worlds and you can collaborate on that care. But it's an important question to ask about what your monitoring options are. And if they say, absolutely not, you're stuck to the regular monitor the entire time, we don't have a wireless option, and you're never off the monitors, maybe that's not a provider that you can work with. Or maybe they're very supportive in every other area, but monitoring is where they draw the line. You have to sort of decide what hill you're going to die on as far as that VBAC support. And if you're like, no, I definitely can't, there's no way I can do a VBAC by being strapped to the monitors, then that might be one of the things that leads you to look outside of the hospital for care, or looking at other provider options to see who can give me that intermittent option or that wireless option to be able to move around during my labor. And then Carrie mentioned another one that is just a huge no-no, that is not supported by medical evidence at all, and that is requiring an epidural or requiring the placement of the epidural tubing for a VBAC. That is not supported by ACOG. That is not supported by medical evidence whatsoever. That is simply a ease of access preference for providers to give you numbing medication and or keep you in
Well,
bed.
and I have found too that once they have accepted that placement, it is a constant barrage of when are we going to numb you up? Are you look like you're suffering? Let's get you in that bed. It's a constant. And if that's not what they want, but they conceded to getting the placement, it's it's a staff issue at that point.
Not to mention, let's talk about the fact that getting an epidural is not comfortable. Sitting through surges to get it, getting poked in the back is uncomfortable. So most people who would get that placement would then just opt for medication, because by the time they're done getting the epidural, they're in so much discomfort from having to hold that position for so long, and sit
And they've
still and
gotten the
all of
douse
that.
of medication because they have to make sure it's working. So,
Right. So yeah, then it takes the edge off a little bit. And so they're like, oh, I kind of like how that feels. Right. And so there's just so many things that can go wrong when you're doing that, not to mention all the complications that can come with having an epidural that people don't like to talk about. All of the potential risks inherent in having an epidural. So then add to that, perhaps this person is trying to pursue an unmedicated birth, or they wanted to delay receiving any medication, and now they've just done it right off the bat because it's what their provider wanted, even if it's not what they wanted for their birth, when it, again, is not supported by medical evidence at all. And what people don't really realize about emergency cesareans is twofold. So, in a true emergency, even if you had an epidural placed, they would knock you out. I know this because I had a true emergent cesarean. I had a working epidural and they knocked me out to deliver my babies, because they're not going to take time to dose an epidural if a baby or a parent is truly in imminent danger. You're out, period. Right. So that's the first thing. The second thing is, according to most of the anesthesiologists that I have worked with in my life, just as fast to give you a dose of a spinal medication, which instead of using the tubing related to an epidural is just a shot in your back of a really dense numbing medication, that's just as fast as dosing up the epidural tubing. Giving you that shot of medication, now you're numb from the boobs down, that's quick. That's just as quick as, okay, sit here so we can give you the medication in your epidural. So it doesn't buy that much time. And in a true emergency, they would not utilize it anyways. So there really is no evidence to support having that hardware in your back in order to have a VBAC or to make a VBAC safer. That's just not supported by medical evidence at all.
hardware. I love that adage.
Yeah. Yeah. I mean, it is. People don't realize that. A lot of people, when they think about, oh, maybe I'm going to get the epidural when I'm in labor, they give me medication and then I don't feel anything and I'm comfortable. No, they put a needle in your back that puts a tube in your back. They tape your back, and then you have monitors on, you have an IV, you have a
Catheter,
catheter in your bladder. Like, there's so much that goes with it.
blood pressure
And
cuff.
yeah, it's not as simple as, oh, yay, I'm so much more comfortable. And I think that catches a lot of people by surprise. We could literally do a whole episode about the pluses and minuses of epidurals. Yeah, because I love an epidural in the right situation, and I love an unmedicated birth, but I think we need to be realistic. Take that class. Do your research about what it actually means to you, your body, and your labor to have an epidural placed. And so when they say, hey, you can have a VBAC, but we require this additional layer of risk, honestly, on top of your VBAC, that's not supported by medical evidence at
Well,
all.
and I
So
have
just
had
keep that in
one
mind.
mom who got the epidural and did not, because the first time she didn't have an epidural. It was, a gas and go cesarean because of eminent stuff. And so this time she's like, okay, I'll get the epidural. Didn't realize that it would slow her labor down, because it doesn't always, but a lot of times it does. So then they were like, we don't feel comfortable adding Pitocin. Your body better ramp this up. And it never ramped it up. And that provider did not feel comfortable giving Pitocin. So she was in another cesarean. And she was so frustrated because she didn't know that risk. And she wasn't a client of mine, she was a student of mine, and very frustrated at the end. She's like, it went so south so fast because I trusted and I didn't do my own research. Yeah, it was a big blow. So just know your
Yeah,
options
it's
so that you can make a
yeah.
balanced decision. That's it.
And if an epidural is an important part of your VBAC for you, that's amazing. If it's your choice to make. But what we're talking about is a provider saying you can have a VBAC with me if you have an epidural or if you have the epidural hardware placed. And that's not medically appropriate to put those requirements on people. And then the other thing is, do they put time limits on VBAC labor? That's a huge one. And we've heard it all. I mean, I've heard it all. I'm sure Kara's heard even crazier things than me as far as like, once you arrive at the hospital, you have 6 hours or you have 12 hours or you have 24
Or you have
hours.
to do your
You
entire
know,
labor at the hospital. So as soon as you have that first contraction, you get in here and you're under monitor the whole time. So there's no laboring at home. There's no relaxed part of labor. It is under the watchful eye the whole entire time. That's the provider's standard because that's what makes them feel more comfortable.
yeah, and often when you see a provider that says you need to do the entire labor under our roof, it's also going to have a time limit on it. It's never going to be a you can labor as long as you need to, as long as it's here. That's very rarely the situation that's offered. And I have been a part of VBACs that took 2 days, 2.5 days, laboring at home, going to the hospital, medically necessary inductions that still ended in a VBAC, which we know inductions take a very long time. And with the right provider, they're not looking at it as the time that's passing by affecting how safe or how successful your VBAC is going to be. They're looking at you as an individual patient saying, how's this parent doing? How's this baby doing? What's going on? Let's look at the whole picture and then intervene when necessary. And as Kara mentioned, there are some, like those who aren't comfortable offering induction, some will not use Pitocin at all in a VBAC, and some will. And some are okay with adding a little top off of Pitocin to help increase your likelihood of having that VBAC if that's what you need. And rather than just doing a cesarean because this much time has passed, what if we help things along a little bit, right? And so if they have, again, sort of arbitrary time limits on I support VBAC if it doesn't take longer than 12 hours or 24 hours, that's not a supportive care provider. You want somebody who's open to understanding that labor is not a linear process and no two labors are going to be the same and no two VBACs are going to take the same amount of time. And looking at you as it goes back to as an individual and a person more than just a patient, and knowing that you're not going to fit in a box to have your VBAC. And that's really what makes a truly supportive care
There's
provider.
one word we haven't mentioned yet, and I want you to kind of cover it a little bit. What is TOLAC?
Oh, Tolac. Yeah, I didn't even think about that. So a lot of people will hear VBAC, vaginal birth after cesarean, and TOLAC, trial of labor after cesarean, sort of used interchangeably. And they are sort of meant to mean the same thing. A TOLAC is what a provider views as the journey to having a VBAC. And a trial of labor means we're going to see what happens. We'll see if maybe you can potentially possibly have a vaginal birth after you've had a
That's why
cesarean.
I
We're going to
hate that word.
try.
That's why I hate it because it's like, trial of labor. Okay, we'll give you a trial of labor. Like, we don't believe it can happen, but if you prove us wrong, like, it's just such a defeatist word to me.
It's a loaded phrase for sure. There's a reason why they use it. And I will say that, like, my close doctor friends and midwife friends and the providers that we really love and work with, even if in their paperwork they're required to use the term TOLAC, they do not use it with their patients. They tell them, your VBAC, you're having your VBAC when you have your VBAC. And then a provider that's not supportive is going to say, when you try for your VBAC, when we attempt a TOLAC, when we
Yep.
attempt a trial of labor after cesarean, they are using really negative words or really neutral words as opposed to really supportive language. And it can be really frustrating to hear them say, I love my doctor. They're so great. And then when the doctor's talking to them, they're saying, well, with a trial of labor, and we're going to give this a shot, and we're going to try, and we'll see how this trial of labor goes. That
Ugh.
as a doula, you're sitting back being like, this is not support. This is almost like they're taking it as a like a burden, this burden that they have to support this trial of labor that this person is doing, and they treat it as something that they're tolerating as opposed to something that they are supporting. And that's just a really loaded phrase. There's so much built into that concept of a trial of labor. We're going to see if you can do it. And you're on trial, basically. Like we're not allowing you to achieve your VBAC in a way that is free and unburdened. We are kind of,
It's a test.
placing these weights on you. It's
It's
a
a
test.
test.
Exactly. We're placing these weights on you to help kind of slow you down from crossing the finish line. And it's so
Well,
frustrating. Thank you for bringing
and
that up.
we
My least favorite phrase in all of labor and
right,
delivery.
and we see, doing hypnobirthing all the time, your language says a lot to your brain and how your body will perform. And so if you're talking to somebody who is dropping phrases like that, and what you're feeling inside is, if you're inhaling every time you hear that, that is not support, that's apprehension. And you're feeling it in your body. So trust your body with that and be looking for the exhale. Like when we're doing this in labor, this is going to happen. We're going to make sure you're safe because we're doing this. You come in when you feel ready, whatever. If you're feeling your body exhale, you're feeling safe in those moments. So you know when you're apprehensive because you're inhaling. You know when you're feeling supported because you're exhaling. You feel safe. Your body is the best read on that. So listen to the words, but more importantly, pay attention to what your body's saying.
Do you want to talk a little bit about how you would interview or what questions you would ask if you were looking for out of hospital care, whether that's at a birth center or with a home birth midwife, and how kind of those questions and interviews change when you're looking at that kind of
Yeah,
care?
because for one, that's the same thing. You're going to want to know that they're supportive of a VBAC. So, are we asking, do you treat VBAC patients any different than you do first time moms, second time moms coming in to have a vaginal birth? Listen to their answers. Yes, I make sure that you're monitored more. Yes, I do this. Or no, we just keep a close eye on you and I'm going to be paying more attention to your words and how you're feeling. Okay, so ask them that. Do you transfer earlier? And what are your signs to transfer me? Is that different than you would do just a regular person coming in having a baby? Obviously, it's going to be a little different because you have an added layer to that care, right? But how often do you transfer and how soon do you transfer? Very important question. Two really important ones are, how often have you done VBACs? Well, we do them all the time or occasionally if you meet the criteria. So how much experience do they have with it? And more importantly, if there is a transfer, what kind of relationship do they have with that hospital that you're transferring to? Do they have a supportive OB that they transfer you to? Is it a good relationship with the hospital, or is it going to be met with a lot of fear and anger and dismissal because you're transferring into that hospital? Because there are some hospitals who think that's very dangerous and they're going to berate you as you come in. That's not the hospital you want. So the midwives are going to be the best judge for that, because when they do transfer, they know which hospitals are going to be supportive and kind, because there are some that are really good with that. And then maybe their OB that usually does that is the only one that they will transfer into. So, really important questions to ask the midwives. They're going to be open and honest with you about that because they don't like to transfer, for one, and they want to make sure that you are low risk so they don't have to, unless that becomes a necessary thing to do.
Yeah, and we're really lucky in California that VBAC is still something that's on the table for home birth midwives. And it's something that people who can afford a home birth have access to. But it's important not to just assume that because somebody works outside of the hospital system, that they're supportive of every kind of birth themselves, right? They could say, in my practice, I take literally the lowest risk possible, and I don't take anything that is outside the norm in terms of diagnoses or previous surgeries or anything like that. if they've had negative experiences with VBACs, if they don't have a really strong relationship with the local hospitals, then they're going to do things to mitigate that risk for themselves as a home birth practice. And so I think sometimes we assume that home birth midwives have this huge umbrella of care and that they'll basically support anybody. But we have to remember that these are also human beings who are trying to maintain a medical practice with a system that is constantly trying to undermine them and their ability to provide that care. And we've seen so many changes over the last decade, even in what midwives in California are sort of allowed to support, that for some midwives, potentially losing their practice or losing a patient or having the hammer come down even more on them is not worth the risk. And so you will find home birth practices that do not take VBAC patients. I know some of the birth centers in San Diego did not do VBAC for that same reason. Some do, some don't. And you'll find a lot of places where birth centers don't take VBACs at all. So don't just go in assuming that somebody outside of the hospital system is going to be the answer, is going to be able to provide the type of care that you're looking for, because not everybody is comfortable, for whatever their reasoning is, supporting a VBAC. And so just kind of keep that in mind as you head down this path. Don't just assume, well, I don't even need to look into the hospital. I don't need to look into a doctor because I know I'll find a home birth midwife who will support my VBAC. That's not necessarily true. So just keep that in mind and make sure you're asking these questions. Be upfront when you're interviewing midwives that you are a VBAC so that they know exactly what you're looking for, and whether or not they can provide that care to you.
And when it comes to finding a provider, if you had a bad experience with your last provider, don't go back to your last provider. Like, find another provider. We see that a lot where they're like, yeah, same hospital, same doc, after they've told us this tragedy that happened to them. And they had other options. But it's like, well, I know that hospital. Yeah. And what happened last time? Like, really dive into, that's one of the reasons we want you to look early, right? Can I transfer to a different hospital? Fresh place, new people, new experience, so that as you're walking into that hospital, all those feelings of inhaling what happened to me last time here. That makes a big difference in how you feel supported in the moment as you're in labor, going through this process again, as you're walking into that same hospital. If you can switch hospitals and providers, please do it. I think that's one of the mishaps that we see a lot, because then they're like, it happened again. Why are they going to be practicing different? That may be what they do at that hospital, right? And it's really hard to think that you're going to be the exception. So if that is a thing that you can transfer, you can figure that out early. Please figure that out early. We want you to be as successful as possible. And sometimes lowering the trauma risk of it coming back to you as you walk into that hospital can make or break your VBAC.
I mean, I am the first person to suggest a change of venue when someone has said, I had a traumatic birth the first time, even if the one they're talking about changing to isn't markedly better. Their numbers are basically the same. It's not a huge change in terms of the type of care that place provides, but it's not the place where they were traumatized before. The sites are different, the providers are different. You talk about that inhale, that activation in our body when we walk back into a place where we experienced trauma. I know as a doula walking back into the hospital where I had my traumatic birth experience, even though I love those providers, and I know that my traumatic birth wasn't because of a lack of supportive care. It was just the circumstances of my birth. But there was a lot I had to work through even to walk into that hospital and support a birth there. And then if I was trying to have a VBAC or if I was having another baby, I really feel that the best thing for a lot of people is to change the venue, change the location, change providers. Like I said, even if you're like, hey, their numbers are basically the same, right? But one place is where you experience trauma and another place is a fresh start for you. Why don't we try that? Because we're talking about providers and we're talking about that external care, but really what it comes back to and what you'll hear us talk about over and over and over again is you and your body and your mind and body being on the same page and your trauma being reduced and mitigated. And when it comes to VBAC, that's so important. And we're going to dig into support and getting the emotional and mental side of it right. But when you think about where you're having your baby and it's the place you had your last baby and your last baby's birth was horrible, maybe a change of venue is in order. And I will mention that a lot to families who had a difficult birth the first time around.
And I hope that you have that opportunity in your town, because some towns don't,
Yeah.
and that's what it is. But if you do have the opportunity, please do that.
And I want to touch a little bit on something that you mentioned and speak to that point a little bit. You're right, it's not accessible for everybody. But if you have the ability, you're not crazy if you're thinking about driving to the next town or relocating temporarily to have your baby. We have families we have worked with who moved across the world
Literally
to
Dubai.
achieve
Literally Dubai.
not even, yeah, like not even just to have a VBAC, but just to have a positive birth experience. We've had families come from Russia. We've had families come from countries in Asia, families come from Central America because they know that there's a certain type of care they can get if they're willing to relocate to get it. And yeah, American families deployed overseas coming back to supportive providers in California to achieve their VBACs or get the type of support that they deserve because those other countries are not going to provide that VBAC support or the gentle birth support that they're looking for. If you have the means, I implore you to explore it, especially if you know, like, I don't have to be here. I don't have to be in this town. I have the means and the ability to relocate for the last 6 weeks of my pregnancy or to temporarily move, or I have family I can live with, or whatever you can do, even if it's an hour away, 2 hours away, if it's a state over to achieve your VBAC, you are not crazy to explore those options. And I think that some people would look at you like you have two heads if you said, I'm going to fly across the country, or I'm going to drive into the next state, or I'm going to do whatever. Who cares? Who cares how they look at you? Go to the lengths that you are capable of going to and the lengths that you feel you need to go to achieve the birth that you want. Period. It doesn't matter what anybody else's opinions are, or what anybody else would do for their VBAC. If you are capable, if you are able, if you have the means, there's nothing wrong with pursuing your birth that you think you and your baby deserve to the furthest extent that you can pursue it. So we are here to tell you that we will support you and you will find support if you're willing to look for it. And I think that's really important to hear. Like, obviously, when we're speaking to people who aren't able to do that, that's why we're here, right? To make sure that we're giving you information and we're supporting you from afar as best we can, because we know that there are maternity deserts and there are places where people are not able to have those options. But I feel like people who do have the option and who do have the choice will often opt not to do it because of what other people might think of them or the way other people look at them, or because, is that crazy? But a safe, healthy birth is never crazy. Having a birth that you deserve is never crazy. And that's what we really want you to take away, is that switching doctors within your town, within your insurance, switching to a doctor across the country, whatever it takes for you to have your VBAC, it's worth it. It's worth it to do it.
And we'll see everybody next week.
Bye.
Thanks for joining us today. And remember, it's your body, your choice, and finding your voice is your power. Be sure to subscribe to our YouTube channel, follow us in all the places, and go to birtheducationcenter.com for our blog and more online education classes. And we'll see you next week.